Okay, so I've got Dr. Martyn Pitman with me here today, and we're going to discuss many topics because a lot has happened just over the last few weeks, particularly at the time we're recording this. Um, so without further ado, I'm sure many of you are familiar with Martin. He's been on the channel many times, obstetrician, gynecologist. Hello to Martin, firstly.
Hi, Chris, and thanks for inviting me back. And you're right, there's a lot going on.
Yeah, so we've got a lot of topics to discuss here, but we're going to begin with the interview that I've done with Carl that has recently gone out on the channel. Um, so I know that you've spoken with him, Martin, and I know that you've been through the interviews. Um, so firstly, just what are your thoughts on the whole situation?
Um, yeah, the interview that I did with Carl and Claire latterly, she came in the last part of it was it was very moving, really, and it was also very upsetting.
Mm.
Um, Primarily because if you just take a step back from it and you think, there was a couple that had been through a major medical life event 10 years ago. Um, and the more that Carl, because I hadn't had any contact with them at all before that interview, so I didn't really know what I was going to be faced with or confronted with. Um, and it became perfectly clear, sort of in real time, as Carl was telling me their story. But I suppose being fortunate in being able to listen to the story that they were recounting, given my 30-year professional history, it was abundantly clear to me what had actually happened.
Mm.
But the more that Carl and Claire latterly went into the detail, it became abundantly clear in real time while it was being recorded that they really had very, very little idea of the actual events that had happened. Um, and that's a massive issue for anybody. Because if you go into any NHS hospital as a patient, then the bare minimum that you can expect, one would hope, is to be told actually what happened to you. And it was perfectly clear from within the first sort of 5 minutes of chatting to Carl initially that that wasn't the case, and there was a huge problem with duty of candor and what should be the very, very basics of a medical contact interaction, in that it has to be beholden on the one of the medical team to actually sit down with a patient and with a couple in their case and explain to them what the hell had gone on.
Mm.
And it's they're both intelligent people, and they had absolutely no accurate recollection of or explanation for what had happened. Um, so from my perspective, with my stance as where I am with the Lucy Letby case, it was enlightening, and it was enlightening from two perspectives, because what we have now, and having listened to Carl's interviews with you, and also what he's put online now with his very detailed and accurate and eloquent description of what it was like to be a patient in that unit, that's given a huge amount of information that confirms, and I think adds to what we knew already. We knew about the sewage leaks, we knew
Mm.
about the general state of the estate at the Countess of Chester and the Women and Children's Building. But I don't think we had the faintest idea of just how bad it was. And it was interesting for me because I said before that the size of the hospital at Chester is reasonably similar to the one that I was based with in
Mm.
my consultant role, but also the age of the maternity unit was the same, in the
Right.
Florence House where I was based, which was the mother and babies unit at the Royal County in Winchester. Um, was very similar to Chester. It was a separate building from the main hospital, built in the 60s, 70s, and because of that, it had structural problems and leaks, and it's the same sort of thing. But I would never have described the unit in Winchester as being really unfit for purpose, and it's perfectly clear from Carl and Claire's description, really from every angle, that unit was very, very clearly unfit for its designated purpose, and I think that's quite startling.
Yes.
So there's that side of it, which I thought Carl was very, very critically descriptive of what the place was like and what it was like to work in for staff. And then, looking through that as a medic, you think, well, that must have had significant ramifications for patient safety and risks of things like infection. And there we have an actual father of a baby on that unit that is witnessing sinks that are cordoned off right next to where your baby's cot is, and brown water, as he described, dripping out of ceiling tiles, brown water in a neonatal unit whilst patients are in there, and it's just shocking. It's just shocking. And then, of course, the other aspect, which is of particular relevance to me, I guess, and also from the neonatal perspective, is what it was like to be a patient at that time. And there's the neonatal aspect of it, which I won't go into any great detail because it's stepping outside of my area of professional interest and expertise. But there are significant concerns about what you're hearing, and there are also quite alarming and pretty frightening similarities between the experience in the neonatal unit and what I think were the deficiencies in the way Claire was managed from the obstetric side. Distinct similarities as far as lack of input from doctors, full stop. But what appears to be, and I'm absolutely sure I'm going to be criticised for making decisions and judgments without seeing the medical records. But all I can say is, bring it on. I'd love to have a look at Claire's and Jessica's medical records to see actually what did happen. But there's enough in their story for me to be able to say that this is not appropriate and not adequate for the 21st century mother going into a maternity unit. Do you want me to go on about the concerns about the?
Please do.
Okay. So for those non-medics, non-obstetricians that may not be aware of Claire's story, and have confirmed that they're happy with us discussing aspects of her care. So Claire was in her second pregnancy, and she previously had a blissfully straightforward pregnancy, and at term.
So can I just stop you a second?
Yeah.
So even that, and I mean, obviously, I come to this from a much less experienced perspective than yourself, but even that in itself, so it's not like it's your first pregnancy, you don't know what to expect. You know what a standard hassle-free pregnancy looks like, and then all of a sudden you're in this situation. So that in itself must be stressful, I would imagine.
Yeah, and absolutely, because I think most couples, when they're expecting a pregnancy, particularly most mums, when they're pregnant and they've been through it all before and have had a straightforward time and a sort of straightforward pregnancy and a straightforward delivery, both of which Claire enjoyed, you're kind of expecting that to happen again. So when and it isn't, and history tends to repeat itself in obstetrics, but not always. Sometimes you can get, nature decides otherwise and can throw spanners in the works, which is basically what part of being an obstetrician and a midwife is, to spot those when they're going awry. So the critical thing from Claire's perspective is that her first pregnancy had been straightforward. She got through to term, she went into a spontaneous labour, and actually got through to the advanced stages of labour almost without knowing she was labouring, and had a straightforward vaginal, so normal delivery. So conceives next pregnancy, so this index pregnancy, the one we're talking about, and she's found in the latter stages, so in the third trimester of that pregnancy, to have what's called an unstable lie. So the most common and the best situation in any pregnancy is at term, so beyond 37 weeks, for the baby to develop into what's called a longitudinal lie. So that basically means that the long axis of the baby is in the same long axis as the mother. And the best situation is for the baby to stabilize in what's called a cephalic presentation. So cephalic meaning the baby's head. So ideally, you want a longitudinal lie with a cephalic presentation. So that means the head is right above the mum's pelvis. So when the baby engages, which is normally between 34 and 36 weeks in a multiparous pregnancy, perhaps a little bit later, the head goes down into the mum's pelvis and stays there. Sometimes a much smaller percentage of babies will go the other way around, so there'll be breach, so the baby's bottom, or the feet in the bottom, will go into the mum's pelvis, but the baby's still longitudinal. So unfortunately, Jessica decided not to do that, and she decided to be unstable. So at about, I think it was 36 weeks, Claire was seen in the clinic, and the baby was found to be unstable or transverse. So that basically means that Jessica, she wasn't longitudinal, she was unstable, so she was flipping all around. It sounded like she was a very, very active baby. So that was confirmed on scan. They would have confirmed that there was no structural or physical reason for that presentation, an unstable lie. So by that, you're checking that the placenta isn't preventing the baby's pole from engaging. And you're also checking things like no big fibroids or anything which are lumps of gristle in the muscle of the womb that are preventing engagement. So that was all confirmed, and then the risks of that were explained. Now, to any mum, that's going to be a challenge. But when you've got another child at home, the last thing anybody wants to do is to be admitted to hospital. But that was the plan that was explained, and Claire reluctantly accepted. The reason for that, which I have to say is a bit archaic, but I'm not going to be massively critical. The reason for what happened, which was Claire was advised to stay in the hospital at the Countess of Chester either until she delivered or until the moment that Jessica stabilised, and then she would either have been allowed to go home, or if it was at an advanced gestation, like probably at about 38 weeks or beyond, they could have considered inducing her into labour when Jessica was stabilised, head down and engaged. Now, the reason for that is the theoretical possibility of getting what's called an umbilical cord prolapse. So if the baby's head down or bottom down, you get a good seal between the baby's presenting part, either the head or the bottom, and the neck of the womb, the cervix. So that if the waters break, plus or minus with contractions, there is a seal which prevents the umbilical cord from dropping out into the outside world. If you can imagine, if the baby's 90 degrees to that, so transverse or oblique, if the waters break and the cervix is wide enough to allow sort of a U-bend of the umbilical cord to drop down through the cervix into the vagina, that's an obstetric emergency. For two reasons. One of them is that if the cord comes out and gets exposed to air, it tends to constrict, so obviously cuts off the baby's blood supply. Plus the fact if when the waters break, the uterus tends to contract, and if you get a part of the baby with the cord beneath it constricting, then that can also cut off the blood supply. So if you get a cord prolapse, that is an emergency to the point where you have to get the baby out ASAP, and you're looking at almost certainly a crash cesarean section. But that was how it was justified. In reality, for that to happen without a lady getting a run of sort of pre-labor contractions enough to make the cervix, because you need the cervix to be a good, I would say, 3 to 4 centimeters dilated to allow a U-bend of cord to drop out. For that to happen without a warning or without being precipitated by an obstetric intervention, so by that I mean us trying to break the waters or trying to do something clever, it's pretty unusual, to the point where, if I compare what life is like when I was a medical student or a very junior doctor in obstetrics, where every antenatal ward would have maybe 2 or 3 mums with transverse lies, latter years, and certainly throughout my tenure as a consultant, I can seldom remember admitting a lady with a transverse lie. We tended to keep the ladies at home, but say, look, if your waters break or if you start contracting, then you must come into hospital ASAP. So I think to obligate or to strongly advise a mum to come into hospital with that situation is pretty unusual. But I wouldn't say it's out of the ordinary. So that was what happened. So Claire reluctantly came in. And she'd been in hospital for a little while. And then what actually happened sounds gravely concerning in my opinion. And again, I stress that all I'm basing this on is Carl and Claire's, albeit very detailed and I suspect accurate description of what happened. So they told Claire that she would be regularly scanned to check that the baby was still in that position. That apparently didn't happen. There were times where she believed that the baby did stabilize, but that was never confirmed. And then and this again, it's critical in view of the concern and criticism that I raised before with you and put on social media about my concern about when most of the Letby indictment cases had their critical sentinel incidents being either out of hours or at the weekend. Well, that again is proved absolutely correct with what happened to Claire, because one Saturday morning, it was decided by Claire had a couple of contractions, so didn't go into labour, but just told the midwife on the ward, on the antenatal ward, she'd had a couple of contractions, and the midwife's response, which again is interesting, was, "Oh, that's brilliant, that's great." And so Claire then had to tell her, "No, it's not. In my situation, it's not brilliant because the baby's transverse." So I've been told to tell you, the midwives, if I'm contracting, because that could be a problem. And then the midwife's response was to go and get what's called a CTG, or a cardiotocogram. So this is a bit of clever electronic kit that allows obstetricians and midwives to do two things. One of them is to use what's called a toco dynamometer. So it's basically a pressure timbre mechanism that sits on the mum's tummy, and it detects upward deflections in the mum's abdomen, which is what happens when the womb contracts. So the top part of the CTG monitors the activity of the uterus, so contractions. And then the bit that was instrumental in what then unfolded for poor Claire was the C bit, so the cardiotocogram, and that basically is an ultrasound monitor that detects the baby's heart rate. So Claire gives a very detailed and for her stressful description of what happened, and that the CTG was put on, and then almost immediately after it was put on, the midwife who was responsible for connecting Claire up to this detected there was a significant problem with the baby's heart rate, pressed the emergency buzzer, and then everything else unfolded. So she was then told that there was a problem with the baby and she needed an urgent cesarean section. Now, I've got massive issues with that. Now, it may be that was an appropriate decision, but I strongly suspect that it may well not have been. And the reason for that is that with the description of what Claire gave of what happened, if any mother goes from standing up or sitting down to lying on a bed, classically reasonably flat on their abdomen, on their backs rather, then there is a profound change in the blood supply to the uterus, the womb, and therefore to the baby that accompanies that. So if you then immediately put a heavily pregnant mum on a CTG, you will almost invariably see an abnormality in the baby's heart rate trace, which is caused by a blood flow change, a hemodynamic consequence to the baby. So I was, this is another area I specialised in electronic fetal monitoring, and I always used to say to people that I train, you pretty much ignore the first 5 minutes of a CTG because you're almost bound to see changes that you can ignore because of the hemodynamic changes that occur. The reason for that is for an abnormality in the baby's fetal heart rate to be severe enough to warrant a crash, which is a category 1, as in the baby needs to be removed from the mum's abdomen as quickly as possible to safeguard the baby's health, which is basically what Claire was told. Then there are only a few things in obstetrics that can cause that. And you're thinking of a cord prolapse, you're thinking of a bleed, an abruption, or particularly a concealed abruption behind the placenta, or you can see it with hypotension, so the mother's blood pressure drops, or you can see it if you're giving too much of a drug to make the womb contract too much and you get too many contractions, none of which was relevant to Claire's situation. So the importance of that is that if you see something on the baby's heart rate in the situation that Claire was faced, and it's of concern, then what you should do is to think, well, what is there anything that I've just done that could have precipitated this? And the classic thing with Claire's situation is the position that she was in. The next thing is to just be patient. And in 99% of the time, the abnormality will get better, but it doesn't sound like that happened at all. So none of that happened. Claire was whistled into theatre, seen by an anaesthetist, and was told that she would have to have a general anaesthetic cesarean section. Now, I suspect that was for two reasons, and I know a bit more now than I did when I first spoke to Carl. So the reasons for that are it's actually potentially quicker to give a mum a general anaesthetic to do a crash cesarean section. And the other reason was that Claire had been given blood thinning injections, and that was probably because she was admitted to hospital and she was less mobile. So they were doing that to prevent her from getting blood clots, so DVTs or PEs. Now, the critical thing about that is Claire says it was more than 12 hours between her last injection and when she needed the cesarean. So from the anaesthetic perspective, it was perfectly reasonable and safer to both Claire and Jessica to do a spinal anaesthetic, so a regional block, to facilitate the cesarean rather than a general anaesthetic. Even more critical in view of Jessica's gestation because she was only 37 weeks. And the other thing, which is again important, is it allowed Carl to potentially be there for the delivery because Carl wasn't even in the hospital at this point. So there was a debate with the anaesthetist. The anaesthetist phoned their consultant, and it was decided that she could have a spinal. So it sounded from the anaesthetic perspective very sensible, very safe. A spinal was put in, and Claire was positioned on the operating table for the cesarean. At some point in time between then and when Jessica was delivered, Carl, who'd been called in, arrived. Now the next bit of the story is, and I've been shaking my head almost in disbelief at this bit. Again, it needs to be confirmed from the records, but both Carl and Claire are absolutely adamant that this is accurate. Claire gives a very, very detailed and accurate description that it took 47 minutes from the time that the cesarean started, so what we call in surgical parlours, knife to skin. So what happens is the anaesthetist confirms that the anaesthetic is functional. And they do that normally by using an ice cold spray to see the level of anaesthesia on the mum's tummy. And then they give the obstetricians a nod, and then you start the procedure. Now, bearing in mind, this was categorized as it sounds as a Cat 1 cesarean section. There would have been a degree in urgency in getting Jessica out. So the obstetricians would have prepped the skin, sterilised the skin, covered Claire up with drapes, and then checked again with the anaesthetist, and then started the operation. Now, in that situation, any experienced obstetrician, bearing in mind Claire hadn't had any abdominal surgery before, so her abdomen surgically was virginal, if you like. Any card carrying obstetric registrar or consultant should have been able to get Jessica out in a straightforward cesarean section within 2 minutes. The height of my surgical prowess in obstetrics, if I needed to, I could get a baby out from knife to skin to delivery within 15 seconds, probably.
Okay.
But most of the time, you didn't need to do that. You could take your time.
Sure.
So let's just revisit this. It took them 47 minutes to get Jessica out. That I never took 47 minutes in the entirety of my career.
Well, I think regardless of the notes, you can't mistake that for 15 seconds, can you? I mean, it's obviously a significant period of time has elapsed. I mean, that's clear.
To question why was that, Chris? Now, and I think I can answer that. It was Saturday morning. And we know already that the anaesthetic consultant, they had to be phoned, so they weren't sort of on the label. No, that's not unreasonable in this situation. The problem that I have with this is Claire's history, because any obstetrician will tell you, or any experienced obstetrician will tell you, that there are several situations as an obstetric surgeon that give you a bead on your forehead of sweat before you're going in to deliver a baby. And one of those, and I had some of the most hairy cesarean deliveries of my career in exactly the situation that Claire was in. Normally, when you do a cesarean section, when you incise through the different layers, you eventually get to the point of making your hysterotomy, your incision in the womb, the uterus, and you put your hand inside the uterus, and you will encounter the baby's pole. as we discussed earlier, either the head, ideally, and you ease the head out and the rest of the baby will follow, or if it's a breech, you ease the feet out, and then there's a manipulative way, a rotational process of events to deliver the baby safely. With the situation that Claire was in, none of those would have happened. And transversalized cesarean sections, particularly, and it sounds from Claire's description and also what was said in theatre at this time, that what happened was that when the obstetrician got into Claire's uterus, they encountered one of the worst and most stressful situations for an obstetric surgeon, of the baby's back being down. So it's like the baby being in a hammock. So the back is down. What then happens is, of course, you've broken the waters, so the amount of sort of swimming pool you've got of room to manipulate the baby is dramatically diminished, and nature then does its clever bit and contracts the uterus down, so you've got no room at all. So you're fighting against a pretty powerful muscle. So then what you have to do is you have to put your hand inside, to get a bit graphic for the non-medical people, and you have to coax the baby to do the decent thing. And the option then is either to try and coax the head round, so you do what's called an internal cephalic version, or you do an internal pedalic version, which is where you go in and grab the feet. But whichever way you do it, it's a pretty difficult, traumatic, stressful manipulation of the baby to make the baby turn at least 90 degrees, and then you've got to expedite the delivery. But for it to take 47 minutes, there must have been numerous attempts to do that.
Right.
Numerous attempts. And then, from Carl's description to you of what Jessica looked like when she was delivered, I can't remember the description you used, but it sounded like she'd been through a few rounds of boxing. But the reason for that is that babies are fragile. And if you've had a burly obstetric registrar doing that sort of delivery, plus the uterus contracting down, and it took 47 minutes, then I'm not at all surprised that Jessica looked a bit pretty. He gave us a story as well of her nose being a bit wonky. So that must have been a very difficult, traumatic, protracted delivery of poor little Jessica.
Yeah.
So what would have happened then logistically? The issue there about that delivery that concerns me, and it goes back a little bit to my concern about what went on at the Countess of Chester, both from the neonatal perspective and, I believe, the obstetric perspective, is who was around at these times on a Saturday morning, and what was the level of perception with the consultant obstetrician who was on call on that Saturday morning about what that team were going to be faced with. Because I can tell you something for nothing, if I'd have been a consultant on call on a Saturday morning and my registrar, irrespective of their level of seniority, had phoned me with that history, I'd have been in the unit anyway. But if I hadn't, I'd have got in my car and gone in. If it had been a junior registrar, I would have gone over the other side of the operating table. This is part of a learning experience for a junior registrar. So let them do it. But as soon as they got out of their depth or struggled, I would have taken over. If it had been a more senior registrar, I'd have got scrubbed and I'd have stayed outside of the operating theatre, but I'd have gone straight in if there was a problem. Now, I don't know. It could be that the guy that Carl describes, it could be that they were a consultant. I suspect that person was a registrar, because they give a description of a big guy who seemed to know what he was doing, and another more junior guy on the other side of the table, which would have been probably a senior house officer who looked like a rabbit in the headlights. Now, their role is to assist the surgeon. Now, if it's a stressful, difficult delivery, being that non-career trainee, junior trainee, is a pretty difficult, stressful situation to be in. So that'd be very, very easy to confirm from the delivery records. So the things you then think about, well, is okay. Well, after a delivery like that, the obstetrician, once the baby's delivered and goes over to the resuscitator, is beholden on the obstetrician to do cord blood samples from the umbilical cord, which will show you the level of hypoxia that Jessica had been exposed to during the delivery. I would say after a 47-minute attempted delivery, that it is inevitable that Jessica would have been to a degree hypoxic. And then that was recognised in real time when Jessica came out, because went over to the resuscitator, came over to Carl and Claire, and then the midwife almost immediately recognised that that Jessica was having problems with the breathing. She was nasal flaring and probably what's called grunting, which is basically the sign that a baby is having is in a degree of respiratory distress. And then was taken back to resuscitation into the neonatal unit, and then the aftercare followed on from that. Now, the fascinating thing is when they were given eventually given an explanation, but only after they'd been badgering the police to get some sort of explanation. I don't believe they were given any details about what I've just been through in that description. But there wasn't even an obstetrician there. And then until they spoke to me, and then latterly to Michelle Warden, I don't believe they were told precisely the most likely cause for what Jessica experienced, which was after a difficult delivery of that nature, particularly in view of the fact that Jessica was only 37 weeks and she'd been delivered by cesarean section, so her lungs wouldn't have been squeezed by the passage through the birth canal from a vaginal delivery. And it sounds as if Claire was given a single dose of steroids, but she was given that, it sounds like, for carpal tunnel syndrome, so a problem in her hands, not to try and dry the baby's lungs out, because normally in that situation you give 2 shots of a steroid, either dexamethasone or betamethasone, 12 hours apart before the delivery. That doesn't sound like what she was given. So each of those factors would increase the risk of Jessica getting what's called TTN, or transient tachypnea of the newborn, which is basically waterlogged lungs, which I think would explain what happened to Jessica, the fact she had the breathing problems, and may well have been at least implicated in some of these, pale episodes that were later described. So then from Claire's perspective, so Jessica goes off to the neonatal unit, and then they've very eloquently described what happened to her and Lucy Letby's involvement with her. From Claire's perspective, the placenta and membranes would have been delivered, and then the obstetricians would have repaired her. And then it sounds like she had a pretty uncomfortable recovery, but that was because the amount of pushing, prodding, and pulling that she'd have had to expedite Jessica's delivery. So that isn't a surprise. The startling thing from the obstetric perspective is that was pretty much it. And I pushed them pretty hard to say, well, surely somebody obstetrically came to see you to go through all of that. No. So, she'd had by anybody's standard, difficult, protracted, stressful delivery. And nobody, not even the operating surgeon, had the professional courtesy to go and see her. And it wasn't as if, some mums now are allowed to go home 24 hours after a cesarean section, which I've always thought is surgically ludicrous, really. But that wasn't the situation, because Jessica was in the neonatal unit, so they were in for several days. Nobody obstetrically came to see her. So I suspect registrar who undertook her cesarean section didn't come to see her to give her a debrief and to explain, and they had no idea even which consultant they were under came to see them at all either, and they weren't given any follow-up afterwards to go through anything. So hugely concerning from that perspective. But again, is that a reflection of the level of consultant input and the way that obstetric maternity patients were treated in that unit? And if that's so, that is way below the acceptable standard of obstetric care for any high-risk patient, which Jessica would have been, having been through that sort of delivery. And then, of course, they pushed because they. The other thing to say about that front is the reason I could be fairly sure that's what happened is Claire remembered that she'd been seen by a doctor before she went home, and when she thought about it, she said, "Oh yeah. I remember that doctor because that was a doctor I saw a couple of years later out in the community when he was a GP." So I can infer from that the only doctor that saw Claire after that difficult and traumatic cesarean section was the most junior doctor in the team in the hospital, because that doctor must have been a GP trainee. So they would have been doing a 6-month attachment in maternity before they went out into practice. And that doctor, who apparently was a bit like a rabbit in the headlights when he saw Claire before she went home, purely came to see her because she was sure she got an infection in her scar, and he was really hesitant in even uncovering her scar to confirm that she got an infection before giving her antibiotics. So that was the only obstetric review that poor Claire had before she went home. So until I spoke to them, they had absolutely no idea about what had happened to them obstetrically. And it's a similar story in the neonatal unit. And again, if you listen to Carl's description to you of what that was like, it sounds to me as if you hardly ever saw any doctors. I think they had no idea which consultant neonatologist they were under. Now, even if you deliver in an NHS hospital at a weekend, on the board in the neonatal unit, there will be a responsible consultant. So 24/7, 365 days a year, there will be one consultant, neonatologist, who is responsible for the patient. And if you're admitted on that Saturday, then you will be under one of those consultants' names. Now, I find it inconceivable that a baby could be on a neonatal unit for as long as Jessica was there, with the issues that Jessica had. And I won't get into the whole intubation thing and giving surfactant, because that just seems completely bizarre to me. But I think, Michelle Warden has commented on that already, that was a very, very unusual thing to need to do in a 37-week baby. But it doesn't take away from the fact that Claire and Carl tried repeatedly to get input from a consultant in the days that they were on that unit, and they never even saw one, let alone one of them actually having the professional courtesy to come and see them and explain. So all of the information they got, which was very, very limited, was from the nursing staff, and the person that they said was the person that seems to be running the place, who sounds from their description as being the diligent, studious, thorough nurse that we now know to be Lucy Letby. So it was a difficult chat with them, really, and it was it's a bit sad, isn't it, when you feel embarrassed for your profession,
Yes.
that a couple can go, this is recent, and they can go through that level of intervention in what should have been one of the happiest days of their lives, and not actually know what happened for 10 years until the doctor, who's played no part at all in their care, sits down with them and they describe what's happened. So then after that, of course, they eventually get seen in the hospital by, it appears, Stephen Brewery and, was it the chief operating officer at the time, Killjoy, I think it was, but no obstetrician. So they still, probably the most important part of their care, which I think perfectly explains what happened to Jessica and the etiology of her breathing problems, but they weren't involved. And again, it just shows, to me, that indicates further evidence of a lack of interprofessional communication between the two departments. Because when Dr. Brewery researched what had happened to Jessica, it should have been blindingly obvious to him that her breathing problems were caused by the antenatal situation and the delivery. And yet that wasn't even mentioned. It was a monosyllabic response from Dr. Brewery to them, and it was the bare minimum of information about what happened. But ultimately, it was that Nurse Letby had played a blinder in their care, it appeared, and had been responsible for recognising and correcting significant issues. And then whoever Killjoy is, it sounds like their role in that whole interaction was basically classical for a senior NHS manager in this situation, which is basically, we need to do everything we possibly can in this interaction to prevent this case from becoming a litigation case, because we don't need any more trouble. So it sounded like it was very much, oh, well, aren't you lucky your baby's well, and how's Jessica doing at school, and all this sort of stuff, which is absolutely typical. And then the questions are, from their perspective, well, how can you be sure that what we experienced wasn't part of what Lucy Letby, they believed or claimed was going on in the unit? And that's anybody's guess, but I have a sneaky suspicion, bearing in mind the way the police worked, and they had 3 looks at Jessica's case and then decided that her case, unlike the other cases, were not suspicious. I suspect, it's truth be known for that, I suspect they looked to see when these episodes that Jessica occurred had, and they weren't when Lucy Letby was on shift. And I suspect that was, I will put that in the not suspicious pile. So astonishing, astonishing,
Mm.
and it just makes you wonder. Huge kudos to Carl and Claire for sticking their head up and being counted really, and being brave enough to take what's come their way. And I have to, the way they've been treated on social media is beyond disgraceful in my opinion. Um, and they're doing this for two reasons. One, to see if they can help other parents that may be in a similar situation, whether or not they're involved in the Lucy Letby cases or not. Other parents that may be in a similar situation to them who want support and information, but also because they believe that from what they've seen firsthand and from their direct contact with Lucy Letby, that there's a very, very different side to the story, and that what stimulated my interest in this, the same really, that the evidence that is presented to them as the evidence that was presented to me made me extremely confident that the evidence that was supposedly presented at the trial didn't equate to any possibility of a safe conviction.
Mm.
And they're not doing anything. There's nothing in what they're doing. There's nothing in what I'm doing that is in any way diminishing the hideous, horrendous time that those poor parents who've
Mm.
lost babies have been through. That's not what this is about, and I would never entertain any idea of doing anything in that regard, as I'm absolutely certain that Carl and Claire wouldn't either. So, and
Mm.
I have no doubt at all that what they've done in starting off this help and support network on social media, I suspect the floodgates will open. And I really hope that other parents like them will get the support and input that they deserve, really.
Mm. Absolutely. So I do have a couple of follow-up questions regarding that. Both things that you touched upon, really, but obviously there's the medical side of things on the unit, and that's one thing, and that's what decides the outcome for the patient. But also, I think what was kind of surprising or possibly even shocking for me was the lack of people skills, you know. I mean, I found it quite staggering that they could go through all this and not have been told what happened, or not have been told, you know, who was leading their care and so on and so forth. That just seems that's not really medical. That's just kind of basic courtesy. I would describe it as. And I just wondered if you'd like to expand on that, if you have any thoughts about that.
It's there were so many bits of the story of their story that unfolded which were completely foreign to me, um, and that aspect particularly. And Carl made a point that um, their needs, their wishes in this weren't that they weren't even approaching excessive. They basically wanted to be told by the professional responsible, so either the registrar or the consultant, what had happened. And that's not at all unreasonable. That should be the first step on the ladder of professional responsibility, um, for any doctor in any discipline, who is given the responsibility and the honour of looking after a patient. And the problem with that, with what has happened to them, and I suspect is rife at the County of Chester from what now is being uncovered, is that if you fall down on that basic professional responsibility in telling people the truth and being honest with them if things don't go to plan, then everything else comes collapsing around your ears. Because having led in risk management and patient complaints for a decade, and when I was a consultant, the thing that most patients complain about if they have legitimate or sometimes non-legitimate issues is about communication. And if you tell the patients and you communicate with them and you're honest with them, normally everything else will fall in line. And I tell you what, if you do that, then you're way less likely to be litigated against. And Claire and Carl's case is a classic example that There was no duty of candor with them. There was no honesty. There was no telling them the very, very basic level of information that any patient deserves.
Hmm.
I don't, I think to my credit, when I was practicing, I don't think I knowingly failed to review a single cesarean section patient that I delivered throughout the entirety of my career, and I prided myself with that.
Hmm.
If there is anybody out there who I didn't see after a cesarean section, I apologise. It wasn't deliberate. And I just thought that was the mere basics of your professionalism as an obstetrician who's operating on a patient, to go and see them afterwards, to congratulate them, to tell them how it went, and to give them any relevant information either about their cesarean or any aftercare issues that were relevant, or anything that was relevant to their next pregnancy, and then to wish them well. And I cannot get my head around how, from the obstetric perspective, also from the neonatal perspective. But you've got to think that unit. What do we know about that unit neonatally? Well, we know the consultants there thought it was appropriate in the level of unit before it was downgraded. They thought it was appropriate to only do ward rounds on that unit twice a week, where most units of that grade, you would have had ward rounds at least twice a day. So are we surprised that they didn't know which consultant was responsible for Jessica's care? Not really. And are we surprised that the consultant and that should be easy to find, I'm sure on their neonatal paperwork it will be as clear as about which consultant was responsible. Are we surprised that consultant didn't think it was their professional responsibility to see Claire and Carl before they went home to have a debrief about what happened? I mean, to find out that your child, when your child was a neonate, was intubated and had surfactant, and to not find out for several years afterwards, I find absolutely astonishing. So yeah, there was a huge amount of guilt, really, as being a doctor, listening to their story. And when they both sort of got, visibly emotional, when I was just giving them basic obstetric information, which has to be correct, to see them emotional. And then there was almost this light bulb moment. Oh my God, this actually makes sense now. And you think, oh God, this is just painful. So yeah, a huge embarrassment, really, as a doctor, that a unit can practice in such an apparently deficient manner, to patients' detriment.
Absolutely. The other question I wanted to ask you is, what prospect do you think Carl and Claire have of getting hold of the medical notes? Do you think that will be successful?
But they've got an absolute 100% legal right to them, and that's been established for years now. So any other parent from the Countess of Chester or any other hospital out there, if you've been through a period of medical care, there are established legal guidelines that justify your request for access to every single piece of paperwork which is relevant to your medical care. And again, you have to question why. I get through the initial stage of the police investigation why there may have been a degree of hesitancy to let Carl and Claire have access to. I completely get that. But as soon as the police have said no, let's face it, they did it 3 times. And particularly after the legal case and the prosecution and the retrial, if you want to push it that far, then there is categorically no reason why Claire and Carl or any other patient shouldn't be given full, unredacted access to their medical records. So for Claire and Carl, that will mean all of her antenatal records from the time she booked the pregnancy through to the time she left the neonatal unit. So I'm talking about maternity and neonatal records. And from the obstetric perspective, the things that are critical are the maternity notes from the time of her admission to the time of her discharge. So that will cover the time on the ward, the decision process, and who made the decision to do the crash cesarean section. Absolutely critical that they obtain the CTG recording of the baby's heart rate. And that'll either be an electronic format, which can be printed out, or a photocopy of the hard paper copy that comes out of the CTG machine, and details of the cesarean section. So who did it, what was their rank and grade, and you should be able to tell either from the obstetric record or from the anaesthetic record the what's called the knife to skin to delivery interval. So that's the time from when the scalpel hit Claire's tummy to the time that Jessica was delivered, because that's the most astonishing aspect of the delivery from my perspective. So yeah, they've got 100% legal right, and that's all supported by GDPR and Information Commissioner's Officer law. And when you apply to the trust, if you should go through, you can either direct it to the head of the maternity service or the medical director of the department or the head of clinical governance in the trust, or PALS. Each trust will have a different way of getting hold of the notes. But if you direct your request to somebody, it will get to the right part of the organisation to do it. They will ask you for identification, a copy of passport, other things like that. And then the legality of it is that you have, I think it's the equivalent of 1 working month, I think, to get the records back to you. And a request like this is perfectly straightforward. So no trust should be able to say, oh, this is a complex request, it's going to take longer. If they claim that, then it's hard to challenge that, but that just gives them double the amount of time. After that, then there is no justification. And ultimately, if a trust is refusing, then you just get the information commissioner involved, and they will apply pressure. But yeah, they've got 100% legal right to full unredacted access. I mean, you have to question if, and Carl said he tried several times that have been declined, you have to question why. You have to question why, because if their management was absolutely exemplary, nothing to hide, then you'd say, yeah, fine, there you go, off you go, have them, nothing to. So if that isn't the case, and they're being obstructive, then why? And also, which seems to happen in quite a few of these cases, is which I don't understand, is why the obstetric management of these cases is being kept under cloak and dagger. I don't know what power the obstetricians have in that unit, but it seems to me that scrutiny of their practice has been rife throughout all of this, really.
Yeah. So that's a pretty full recollection and response to Carl's interview. So I really appreciate that for you sharing your expertise on that. We've got some other topics to discuss as well. I don't know if we're going to get through them all, because I know you're going to have a lot to say about the next topic. So there's the maternity scandal, I think it could be described as now, crisis. I don't know how it's described. I kind of resent this use of the word crisis all the time, because they still say cost of living crisis. I'm like, well, that's just the actual state of being that exists. It's existed for years. It's not really a crisis anymore. And similarly, I don't think the maternity situation is a crisis. I think it's a decline in the standard of maternity services. I don't think it's a crisis. I think it's systemic. I think it's been going on for a long time. But yeah, there's obviously been this issue in Nottingham. Well, we're recording this at the start of July, and there's recently been this issue in Nottingham, and I know it's been pointed out by Sir David Davis and Mark MacDonald that there's a lot of overlap between Nottingham and Chester, to say the least. So what are your feelings about the whole thing? I know you feel strongly about the maternity situation, the way that it's being dealt with. Tell me your feelings. Anything you have to say.
I could go on for the next fortnight, Chris.
I know. I'm not looking. We'll limit you to the end of this interview. We'll park the other topics.
It's an issue of particular pertinent importance to me, because let's face it, that's why I'm here now, and that's why I'm not, sat in my office at the hospital in Winchester, because in 2019 I spotted locally quite a few of the problems that have now become part of a crisis. And I completely agree with you. Crisis is a completely inappropriate word. Crisis is a word which should be restricted to an acute short-term problem, and this is very, very far from that. This has been going on for well over a decade. I think most maternity professionals, most maternity patients, current and future, have waited with a significant degree of anticipation for this week, or last week and this week, because there's been a 4-year wait for Donna Ockendon's report out of the Nottingham maternity service, and the Amos review, which I believe was just purely a temporising measure by Wes Streeting, because he was being pressurised by parent groups quite appropriately to commission a judicial independent review into maternity services, and hesitant to do that. So I personally believe the Amos review was a temporising measure on Wes Streeting's part to defer doing that until Donna Ockendon's report came out. So the Ockendon report was very detailed. It was very comprehensive. It was presented with almost Oscar-winning standard of presentation style by Donna Ockendon. But what did it tell us? What did it tell us that we didn't know already? And didn't know already, for those, I expect most people watching this are very well aware of what's been going on in the UK. But if you go back 10 years ago, this all started with Bill Kirkup's review of Morecambe Bay in the Lake District, which was the first sort of condemning review of UK maternity service. And it showed many things, but one of the main things it showed was overemphasis being placed on what subsequently became known as the normalisation ideology. So that was a focus by midwifery groups to promote vaginal delivery almost at all costs. So it was a very anti-obstetrician, very anti-intervention, and it basically adopted elements of antenatal and labour management designed to achieve vaginal delivery. So it was very anti-cesarean section. Following on from that, we then had the first time Donna Ockendon got involved, which was following the uncovering of the terrible stuff that happened at Shrewsbury and Telford. So that was another massive scale issue with maternity care. And Donna Ockendon went in there with the team and produced a report and a series of recommendations. And each time this happens, it's exactly the same. And it's exactly the same as I predicted would happen this week, or last week and this week, which is a glitzy media presentation with all of the press involved. Donna Ockendon on every single national news bulletin, and then on the front of every national newspaper, and politicians making statements about how terrible this is, and we will learn from this, and action will be taken. And then what happens? We then move on to the next one, which chronologically was East Kent. And each one of these crises, hate the word, was instigated by not by professionals, not by the government initially. They were instigated by grieving parents on every single occasion. And East Kent was pretty much exactly the same. Again, focus on normalisation ideology. And then that brought us up to the most recent one. So you've got Donna Ockendon again, because she seems to be the one of the sole people in the country who is qualified and trusted enough to do these detailed investigations. And I see the point of that, because she's incredibly supportive and compassionate to the parents. So I do get that from that perspective. But then when you look at the recommendations that came out of the Ockendon report, they are identical to every single one that predated it. So we're in the situation now before the Ockendon report, before the Ockendon Nottingham report, of having something. I think prior to that we had something like 782 recommendations that came from the previous reviews, of things that needed to be changed to improve the standard and safety of UK maternity care. And there's very, very little that came out in the Ockendon review that told us anything we didn't know already. I wasn't surprised, but I was massively disappointed when you think of the the weight that parents have had, the phenomenal financial cost of all of these investigations. And there was a bit in Donna Rockenden's presentation where she said that, enough was enough, and these recommendations made before, and unlike previous times, I'm going to make sure that the government are obligated to make changes. Well, you have to wonder why that hasn't been the case all the way along. I posted on X yesterday that if Bill Kirkup, who was the very experienced independent chairman of Morecambe Bay, if you go back and read his recommendations following that, if those had been instigated back then you just have to wonder, and if appropriate accountability would have been brought in. It is a travesty to think about the number of mums and babies whose lives would have been saved. But no, we just kick the can down the road, which is now a very, very rusty can. We wait for the next disaster, and then we do another review. And Amos, I don't even know where to start with the Amos report. The main recommendation that's come out of it is the development of a maternity commissioner. So this is going to be a legislated position with responsibilities to deliver. So potentially that is a positive development, but it's a question of whether or not one individual can deliver, and whether it's appropriate to put all of that responsibility in the inbox of one individual. The huge disappointment from the Amos review is what happened 24 hours before it was released, and there were stories circulating which have subsequently been confirmed that Bill Kirkup, who is an individual, did the Morecambe Bay independent review, did the East Kent independent review, and was a very, very positive recruitment into the advisory panel for Amos, resigned his post 24 hours before Amos reported her finding. And it turns out that the reason for that was that there was a dispute between Bill Kirkup and other members of the panel about what to include in Amos's report about the normalisation agenda. And it appears that the independence of this report included the ability to manipulate the details of what was reported. So it was decided that it was not appropriate to include details of the presence of normalisation ideology and the dangerous effects that has on mothers and their babies. And I haven't read all of the, I think Bill Kirkup's been interviewed about his position on this. And I just, for that to have happened, for Bill Kirkup, who I've got a huge amount of respect for, to take that decision, somebody of his position, seniority, and integrity, to resign because of that, that's massive. I'm afraid, from my perspective, it questions the validity and the integrity of the entire Amos report, if that is the case. So, and then of course, where are we now? Well, we hear that Donna Rockenden's got another couple of years to continue her feedback into Nottingham to make sure improvements are made there. And she's already now been signed up to investigate the maternity services of both Leeds and Brighton. And I have no doubt at all once she gets in there that it will be the same massive escalation of concern once other affected parents come out of the woodwork. So one has to question how many more years that is going to take before we get meaningful and objective change to and improvements to the safety and efficacy of UK maternity care. Now, where we go from here, I don't know. If I had to put money on it, I suspect, with view of the amount of criticism about the Amos review, I suspect that the government and James Murray, the rabbit in the headlights appearance, new health secretary, particularly with the potential of Andy Burnham coming in, he's going to want to appease and to appear to be the messiah for the Labour Party that he's being built up to be. if I had to put money on it, I suspect they are going to buckle to the wishes of um, the parent groups and to agree to have a public inquiry. But of course, the issue with that is that's going to take years.
Mm.
But of course, and it's going to cost a hell of a lot of money. But of course, from the government's perspective, it will give them time to kick the rusty can further down the road, and then it won't be their problem because it will be quite possibly, I suspect, another government in charge in 3 and a bit years' time, and it'll be left to them and the next health secretary to sort it out. So it's something needs to be done, as I said in 2019 when I raised concerns locally and in my career over that. Something needs to be done. The time has more than come. Enough mums and babies have been injured and have avoidably died as a consequence of lamentably poor standards in maternity care in this country. And one has to wonder how many more babies and mums are going to be sacrificed before that situation is rectified.
Yeah, absolutely. And the follow-up question to that really is specifically this overlap between Nottingham and the Council of Chester that, as I
Oh
say,
yeah.
has been noted. So yeah, just give me your thoughts on that as well.
Well, there were a couple of summaries that came out of it's principally the Ockenden report, where I think anybody reading it who's had any kind of understanding of what was going on at the Countess of Chester and particularly the Lucy Letby indictment cases, the ones that she was convicted for. It was quite chilling, really, because you read through some of the main criticisms about what was going on in Nottingham, and it's an absolute carbon copy of what was going on in the Countess of Chester. I mean, almost scarily so, in that I just think
I mean,
of a
I
few.
was surprised by how close it was.
Oh, it
I
was
mean,
incredible. I mean, it was
it's
almost
unbelievable,
eerily.
wasn't it?
It was almost eerily, even down to, and it was cross specialty as well. It was obstetrics and neonatology. It was just think a few things about recurrent intubation of babies and the insulin cases and hypoglycemia and you just think, wow, this is, and lack of senior involvement, lack of consultant involvement, lack of out of hours cover. There were so many familiar themes. It was bordering on uncanny. But as you've been saying, as I've been saying, and I think most commentators that have been vocal in the Lucy Letby case have made the same comment that what I believe has been uncovered at the Countess of Chester is absolutely identical to all of the other systemic failures that have been uncovered at all of the units around the country. The sole difference in Lucy Letby's case is, rather than an organisation accepting that it's got systemic problems and addressing that, learning from it, changing their practice, appointing more consultants, etc., etc. What the sole difference at the Countess of Chester is, rather than accepting that and the seemingly obvious deficiencies in care that were provoking these adverse outcomes, they decided to shout murderer and commence a 21st century scapegoating witch hunt, which is becoming increasingly obvious, I think, to most people.
Yeah.
So it was uncannily similar.
Yeah, absolutely. I suppose another follow-up question that would progress logically from that is we know the situation that Council Chester was bad. Do you think there's a possibility or perhaps even a likelihood that it's worse than we know?
Oh yes, yes. I think it probably is. Yeah. And I think a degree of that might come to light with Carl and Claire's plans, really, with this patient help group, because I think they were both surprised at what has been uncovered about their care. I find it inconceivable, Chris, to be honest, that there aren't a significant number of other parents out there that have had similar, identical, quite possibly, I hate to say it, worse experiences. many of whom I suspect are sitting at home not having the faintest idea of the truth about what happened because of another thing that came out of both Ockenden and Amos was the complete absence of duty of candor, the complete absence of truth, the prevalence of a cover-up culture. I just find astonishing. So yeah, I think it's inevitable, and you've just got to look at what happened to Carl and Claire when they eventually did get to see somebody senior in the organisation. What they weren't confronted with then was the truth. They weren't confronted with a consultation that represented an appropriate duty of candor. They were presented with the presentation to them of minimal clinical details to cover off their questions, which didn't even include details about their obstetric management. So yeah, I think it's an inevitability, and if they're going to cover up that, then you have serious questions about things like their reporting, which, let's face it, most of the reporting of adverse outcomes is akin to marking your own homework for an HS trust at the moment, which is something that is going to have to change. Yeah, I think it's inevitable. It is an inevitability. I think that as time progresses, depending on where this goes, that more cases are going to be uncovered.
Yes, absolutely. So there's a few other topics we could discuss. I think an interesting one that has just occurred at the time we're recording this. By the time this goes out, it will have been a couple of weeks past. But that was the MP, Lucy's constituency MP, indeed, Jesse Norman, speaking in the House of Commons. Now, let's talk about his comments first, and then we'll talk about the response. So what did you make of the fact that he spoke out?
I think I'm right. So he's actually Lucy's parents' MP, isn't he? I think.
Oh yes, of course. I mean, it was actually the last place Lucy lived in the UK because she got banned from her house, of course. But yeah, that's absolutely correct. Yeah.
Obviously, any of us knew that was coming. I thought it was a very powerful and succinct presentation. I guess that her parents are fortunate and they've got an MP who is pretty senior, being the shadow leader of the House. One has to wonder if it was a more junior MP, whether or not they would have been supported in raising that question in the arena that Jesse Norman was able to. So I think in the time allocated, very, very clear from what unfolded that Lindsay Hoyle was going to rigidly keep him to the minute that he'd been allocated to raise his question. So I think in the time he had available, he made his point very clear. And I think a very interesting change in stance from not that long ago when David Davis did his German debate, when he's given longer, but the response that was batted back to him was quite clearly a civil servant produced whitewash, wasn't it? Really, it said nothing. It was basically, well, she's been through a trial, she's been through 2 leaves to appeal which have failed. That's it, and an appeal has been made to the CCRC, so we're not going to intervene, which was perhaps predictable, but very disappointing. So what came from it was initially Lindsay Hoyle, the Speaker of the House of Commons, pretty unusually aggressively, I thought, particularly in view of Jesse Norman's seniority, absolutely knocked him back and told him to sit down and that he wasn't going to be treated like this in a typical arrogance, really. And then the jokeable thing was the amount of time that his counterpart, so the leader of the House from the Labour Party, was allowed to waffle on about other matters.
Yeah, I know.
Way longer. Didn't really say anything of any great substance. And then at the end,
it was all waffle, wasn't it?
It was
as usual.
And then at the end said, "Oh yes, well, but interesting." It was an interesting admission, because he did say that there were members of the House from both sides. Which I didn't equate to cross-party support, which is how it's being viewed by some people. That there were, so I viewed from that at least there were both Labour and Conservative members of Parliament who had expressed significant concern about the safety of the conviction. So what came of that was that the leader of the House was going to escalate that, I presume, to the Justice Secretary and the Secretary of State for Health, I presume, although I would say, well, it's out of our department now, and encouraged Jessie Norman to do the same. So I think that is a huge development, an unpredicted huge development, because it shows that there now is recurrent political interest in Lucy Letby's conviction. And that it's going to be escalated and brought up. And David Davis isn't the sort of character that's going to let this drop. He's already failed so far to get a response from Cheshire Police about alleged perjury on Ravi Jayaram's part, and has failed to get any clarification from the Cheshire Police about release of their details of their investigation process for Operation Hummingbird. So, that in itself is questionable, because if the police genuinely believe that Operation Hummingbird was exemplary and was squeaky clean, then you would say, that's fine, of course you can have it. Yeah, we're happy. Completely open. Get any other police organisation to come in and scrutinise our investigation. That's absolutely fine. But no. Secrecy, shut up. You've got shut up the barricades, and you've got no right to see these documents. So no, we won't release them. And that doesn't smack of honesty and openness, does it really? So
absolutely not. Absolutely not.
So yeah, I think that intervention in Parliament was very significant.
Yes. Yeah, I mean, it felt like a significant concession by the response. I mean, I was sitting through it, and they were, I just want to say that this is reflective of how wonderful everything is. It's just the usual nonsense they go on about. And then I thought, I fully expected at the end of that they were going to say, well, of course, the CCRC are making the decision and we can't do anything. I was really surprised when they made that concession, and that kind of indicates the mood, I think, to some extent.
Yeah,
whether anything actually tangible will happen because of that, I don't know, because I don't place an enormous amount of faith in the political process generally, I would say. But it did feel
there's a few high profile things. No plug intended, Chris, but including your book, that are happening over the next few months that are going to be impossible for MPs not to become increasingly involved with. I think that they are going to be forced to take a greater interest.
Yeah, absolutely. Speaking of that, this forensic scientist, Dame Sue Black, has spoken, and I had the feeling from reading the article, knowing how these things work, that she kind of had this question sprung on her a little bit. I don't know if she did, or if she'd been allowed to prep for it or not, but she wasn't really there to discuss the Lucy Letby case, and I feel a year previous to this, and certainly 2 years previous to this, she just would have said, I don't want to talk about it, or she's been convicted in the court of law, or stuff, words to that effect. So I thought it was quite significant that she said clearly there are problems with this conviction. What did you make of her comments to Telegraph?
Yeah, again, she's somebody of immense scientific stature and in a very, very knowledgeable senior position. So I think you just got to, if you should take a step back from our position on this, and you just look at the now growing enormity of people across the scientific, statistical, political, police communities that are coming out and saying, "Whoa, this," very few people are saying categorically she's innocent, but an increasing number of very learned, qualified, senior, experienced individuals are saying this conviction, without question, is lacking in objective quality evidence, and that has to surely mean that, at best, the evidence that was used to convict her was unsafe and needs to be looked at again. And we're getting people of her stature, and particularly in that field of forensics, again, a very, very powerful and influential intervention. So yeah, it's every goes by now. You think, well, there's another
Mm,
another person whose name can be added to the list of
mm,
skeptics of this, really.
mm.
And I don't think it's surprising. I
No,
really don't.
no. I think all that is needed is for the person to have the chance to look at it. If the person does has the chance to look at it, they will inevitably conclude that this conviction is unsafe, at least. Um, and that's because of the very poor standard of evidence that was used in the case, not least the medical evidence that was used. And when I say very poor, I mean I've told this to a journalist. Probably by the time this is released, you'll see that. When I say it was very poor evidence, that's the most generous thing I can say. And that's not being critical. That's me trying to be fair. It's just staggeringly poor. And of course, people of her caliber can see that. And all it really takes is for someone to have the opportunity to see what she was convicted on and what was said in court and the basis of that, and have the opportunity to speak. And I don't see anyone ever coming out and say, well, I think she was convicted safely and I think the evidence was really good. It would be extraordinary, astounding for me if you ever saw anyone with any kind of credentials or qualifications who said that. And that's why it hasn't happened and it won't happen.
Well, I might, you've only got to think about what's happening. It's next week, isn't it? Your book's out, and I think you will get. There's going to be three different groups, aren't there, reading your book? There's going to be the people like me who are very much on the side of the conviction was unsafe, at least. You've got the people who are absolutely adamant that the conviction was safe and that Lucy Letby deserves to be where she is. And there's going to be a sizable group who go into shops or go onto Amazon next week and think, oh, that's interesting. That's going to be up to date. That's the most up to date and comprehensive text on this subject. So that you're going to have the people that want to be persuaded or buy your book to look at the most comprehensive, I believe, accumulation of evidence base about it. And it's inconceivable to my mind that anybody with a modicum of intelligence will be able to read your book and not at least say, "Whoa, this is really worrying."
Mm.
Um, so,
Yeah, I
but
mean,
that's
I
that's not having
think
read it yet.
I think it's okay for me to say that I recorded the audiobook a while ago, and people won't know what the process is. I certainly didn't, but you put headphones on like this, and you have your producer in your ears, and the producer was great, is fantastic at what he did. It's a very grueling process recording an audiobook, particularly one of this complexity. But I think we got a certain number of chapters in, maybe four or five, and he was like, I mean, if what he said to me, if even 10% of this is true, there's just no way that this can be upheld. And I think by the end, where there was another 15, 16 chapters, I think he was just blown away, and he went into it. The only thing he knew was he saw it in the news when she was convicted. He didn't know there was any, question marks about it. He had no prior view. And I think I left him with very little doubt about the safety of the conviction.
Yeah.
And I don't see any other. And I don't say that as a boast or anything. I just think if things are laid out evidentially, I find it impossible that anyone who's even remotely objective could think this is a safe conviction. And that's why you're getting people like this forensic scientist speaking out. It's why I've been able to interview so many people. It's why I'm fortunate to have people like yourself on. It's why I have people emailing me. It's why there's 1,000 people and 19 nurses now. And it's why no one comes out and says, yes, I do think child C died due to air. Yes, I do think child D died due to air. I don't think the blood was relevant in the case of child E. Or, it's because it's speculative nonsense, essentially. And people can see that. It's
Yeah.
just obvious.
Yeah.
So yeah, I mean, I think it's devastating what's happened here. And the tragic thing about this whole situation is there can never be a winner. Um, you know, I hope Lucy will be exonerated, and I hope the parents get the truth, and I hope that they can come to accept that they were led up the garden path, not deliberately by the police. As I've said numerous times, the police tried their hardest. and they believed that they were correct. It's just
Mm.
unfortunate that they made a pig's ear of the investigation.
Yeah.
Um, and whatever happens, some infants have been poorly treated, we believe. I think there's overwhelming evidence for that. There's been avoidable deaths. Someone has been incarcerated for years and years and years and had their young life taken away. Millions, tens of millions have been wasted. And the whole thing is just massively unsavory, and there's not going to be a day of celebration ever. It's just going to be, thank God that's over. So yeah, it's terrible thing that's happened. But the only good thing that's come out of it for me, really, is that I've met loads of amazing people through it, and that's, something I'm really grateful for. But
Mhm.
the spectacle and the spectre of what we witnessed is awful. And I think another thing that makes it even worse is we obviously suspect there are many more thousands of
Mm.
innocent people in prison.
Yeah.
So yeah. With that being said, let's finish by just asking about Amanda Knox. I must say as a disclaimer before we discuss this, I haven't had time to listen to this podcast yet, but Martin was in the most recent episode of the Amanda Knox podcast. So I just wonder if you had any reflections on that, or anything to say about it.
Yeah, very, very quick response. I've got to shoot off.
Yeah.
It was a privilege to be invited to take part in it. I'd listened to every episode of it prior to the point of being approached, and thought it was very, very well done. Um, Obviously extensively researched, and her team were very, very impressive. So it was it was a privilege to be approached, and I knew a bit about the details of the poor porters in Chester. Their story was appalling, wasn't it? And it
Mm.
shows the perils of whistleblowing in the NHS, which which to my detriment, I know only too well. So I hope my input in that
Mm.
it was useful. I hope, and sort of in highlighting what I've said all the way along. Again, another reason why I got involved with the Letby case, in that it was pretty clear
Mm.
to me that Letby, well, I don't think she realised, was a whistleblower. Um, and wow, did she suffer as a
Mm.
consequence of doing what she believed was her professional
Mm.
moral responsibility and
Mm.
standing up for adverse patient events.
Mm.
So yeah, it was very, very humbling to be
Mm.
invited to be involved with that podcast, really.
Mm. Yeah. Well, thanks for sharing your thoughts on that. Thanks for everything you've shared today. I will let
Not
you
at all.
shoot off because I know you've got stuff to do. So
Okay.
we'll have you back soon. We've got 11 pages of questions. We're not done yet. The next time we speak, 25 other things will have happened. So
I'm sure.
we'll talk again soon. And thanks
Okay,
again for your
Chris.
time. And I'll see
Thanks
you
a
again
lot.
soon.
Have a good day. Bye.
You too. Cheers. Bye now.